Hi Ninja Nerds, in this video today we're going to be talking about nephrotic versus nephritic syndrome. So if you do like this video, make sure to give it a thumbs up, comment down below, and don't forget to subscribe here to Ninja Nerd Nursing. And then go over and check out ninjanerd.org. That's where all of the notes and illustrations for these lectures that we put up here on YouTube are available for you guys to utilize. And let's get started here talking first about nephrotic. So as we go through our renal series, we've been going over what type of structures and what all the functions are, and then we started going into different disease pathways. And what we want to talk about here is the difference between a nephrotic syndrome versus a nephritic. So we talked a little bit about nephritic when we talked about acute glomerulonephritis, but I want to hit on just this quick video on the review of our filtration membrane and then our barrier, and then how we have nephrotic and nephritic and what's the difference between them. So if you're getting ready for a test or the NCLEX and you're like, I need a quick refresher, then this is the video for you. So real quickly, we have here our glomerulus with our afferent arteriole, our efferent arteriole, and then we have our structure in here, right, our glomerulus. And then we have our renal corpuscle with our Bowman's capsule, our Bowman's space in here. And then we want to quickly run through what are the different areas here of our glomerular filtration barrier, right? What we're looking at here is we have 3 different steps. If you forget, you can check out the glomerular filtration rate video. But we have our capillary bed that has fenestrations, right? So we have these fenestrated capillaries within our glomerulus. Then we have our glomerular basement membrane, which is this blue structure here, which is negatively charged. And then we have our podocytes, right? And what we're looking at here is how things funnel through from our blood into our nephron here, so they become filtrate and becomes urine. And this is the area where we can decipher whether we have nephrotic or nephritic syndrome. So with nephrotic, we're basically talking about the barrier here, but if you're going minutely into the pathophysiology, we're mostly concerned about the podocytes. So what happens here is we have some sort of damage to the podocytes, and because of our glomerular filtration membrane, what it does is it's trying to keep red blood cells and proteins up into the body, right, and allowing for our electrolytes, our nutrients, toxins, and wastes, and anything that we don't need to get filtered out into our urine. When there's a disruption there, we're going to have some issues. So we have damage, or we have inflammation, and essentially along the way in our nephrotic, we get a podocyte injury or podocyte damage. And then once we have that issue, these can open up, okay? And we start to get a large loss of proteins. When we do get that enormous loss of proteins, that's where we start to look at then what is going on in nephrotic syndrome. When we have a patient that comes in, we think they have nephrotic syndrome, one of the big things they're going to say is they're tired or fatigued. And then they're going to have very, very low proteins, right? Because they're going to be losing a lot of proteins through their urine. So when we do check their urine or their blood work, they're either going to have a lot of protein in their urine, or they're going to have a lot of protein missing in their blood. And when we see this as a patient, we're going to be seeing what we call a loss of a specific protein. What's the one that's synthesized in the liver? That's albumin, right? And what is albumin used for? It's very important for us for transporting water, for being able to form clots, being able to do a lot of different things in the body, getting nutrients to areas it needs to, and hormones in areas it needs to. So when we have low protein, especially low albumin, we call that hypoalbuminemia. So if they have low albumin in the blood, right, they have hypoalbuminemia, they're going to have high amounts of protein in the urine. We call that proteinuria. Specifically with nephrotic syndrome, it's going to be so high that it's actually going to be greater than 3.5 grams per day. And then we're also going to have some blood work done, more than likely increased BUN creatinine. And then that kind of creates the picture here of what nephrotic is, but one of the biggest things, or the biggest keywords you're going to be looking for on the NCLEX when you are taking this exam is the urine, and the urine will always be described as foamy urine. So let's recap really quickly. We have a patient who has nephrotic syndrome. They're going to have an increase in proteinuria, right, over 3.5 grams per day. And then because of that, they're going to have low albumin anemia, meaning they're going to be at risk for things like edema, clots, hyperglycemia. So what we're looking at for this patient just specifically on this is giving back the albumin, right? So we may administer them albumin, and then we're also going to be looking at getting that edema off by giving them diuretics. And then there's a lot of other things that we can do to treat this patient, but this is just an overarching of what's going on with nephrotic. Now when we move over to nephritic, what we want to do is we want to think about what's going on with this patient. Within nephritic syndrome, we have inflammation specifically. Again, we have some areas of issues within the filtration barrier, but more so problems with the glomerular basement membrane. And if you've seen the acute glomerulonephritis video, you'll know there's all about the antibody antigens that get stuck in here. But most importantly, it's inflammation within that glomerular basement membrane, also known as our GBM. So because we have that inflammation, at this patient, they're going to have some of the similar complaints, right? They're going to be having maybe fatigue or headache. But then as we start to look into their urine and what's going on with their urine analysis, we can start to see some differences as well. So with this patient, we're going to see things like they're going to come in and say, I'm having trouble going to the bathroom, or I'm not peeing as much as often. So we call those things alloguria and uria. They may be complaining of blood within their urine, so we call that hematuria. This patient will also have proteinuria as well, but not as high as someone with nephrotic syndrome. So it won't be as high as 3.5 or greater, but it still be slightly elevated. And then this patient's also going to have this dark, murky looking type of urine, which we call that Coca-Cola colored urine. So then when we look at all this overarching issue with nephritic syndrome, it is an overall of a decrease in the filtration rate with that Coca-Cola colored urine and that proteinuria and the hematuria. So if you want to remember anything within these two to be able to delineate between nephrotic or nephritic, just think if it has blood in the urine, it is going to be more than likely a nephritic and not a nephrotic, because we didn't talk about that over on the other side. Then we're going to look at our blood work, right? Increased BUN creatinine. And then we're going to look at some of the other issues. This patient might also have some issues with hypertension. If they do not have a history of hypertension, then they're all of a sudden a new onset of blood pressure issues could indicate there is something wrong with the kidney. Or if they already do have a problem, they could be exacerbated by having this nephritic syndrome. So we want to think about what's going on with this patient. Is there could be some type of infection that had occurred, specifically in some type of PEDS patient where they had any type of streptococcus infection that went untreated, and then 2 weeks later they start having issues with going to the bathroom and dark urine. They could have edema in areas, facial edema up around the periorbital, right, or the lips. Later, it could be progressing to the feet and to the hands. And then if this is an adult patient, not only having that peripheral, but also having then a pleural effusion or a pericardial effusion and ascites as well. So a lot of edema can be occurring. And with that, we're looking to fix this patient's underlying cause. With nephritic, it's more so identifying what that underlying cause was that pre-exacerbated this type of kidney injury. So we could be looking at things like an infection, so we're going to be giving them antibiotics that wasn't treated. If they're having issues with hypertension, we're going to give them antihypertensives. And then we're going to be looking at trying to give them some type of fluid replacement or any other underlying issues that they have. So then if we take a step back and we start to look at what's going on with both of these patients, we can start to think that, all right, once we treat the issue on both sides, whether it's giving somebody antibiotics for their nephritic issue or giving albumin for the nephrotic, the care for both these patients essentially becomes the same, right? It's making sure we have adherence to medication, making sure we are monitoring their eyes and nose. If it's an adult patient, making sure that their output is around 30 milliliters per hour. If it's a pediatric patient, it's 1 milliliter per kilogram per hour. And then we also just want to make sure that these patients are getting better. It's frequently checks with the vital signs, checking those electrolytes through blood work, checking the kidney function through blood work, and making sure that this patient's problem, whatever it is along either syndrome, is getting better and not worse. And then any other modifications that we need to give them with diet, we want to make sure we are following along with them as well, whether it's replacing something, taking out sodium, adding in protein, or anything else that we need to do in order for this patient to get better. So remember, as we go from nephrotic or nephritic syndrome, identifying what the issue is, essentially the nursing care starts to look very similar at bedside once we identify that there's something going on with the kidney and the glomerulus. So I hope this video made sense. I hope it cleared up for you any issues you had with understanding nephrotic versus nephritic. And as always, until next time.